Okay, good afternoon, everybody. For those of you that do not know me, my name is Katie Rankin. I'm with Ally Medical Emergency Room, and I'm co-chair with Rich Siegel for the Health and Wellness Committee for the Chamber. Our fearless leader can't make it today, so I'm going to take over duties. Today is a really important webinar, and I'm really happy that we were able to get everybody together to get this out. Today, we are going to be talking about suicide prevention. Suicide rates are higher in the LGBT children and young adults. So I want y'all to join us as Sage Recovery, Starlite Recovery, and Austin Oaks all tell us a little bit on how they're helping with suicide prevention and how we can all do more to support our friends and family who are struggling. I think everybody knows somebody who is struggling right now coming off of the pandemic. I think that ripple effect is still happening. So it's wonderful that we're all able to take this moment and get together. We have such a wonderful network of people that can help your loved ones. So please utilize this webinar and share it with your friends and your family and anybody that is looking for help. So we're going to have 3 speakers, like I said, and then at the end, we'll do a Q&A. So if you have a question that you want to ask, you can put it in the chat so you don't forget it, and then who the question is for, or it could just be for anybody. And then what we'll do is at the end, I'll go through and make sure that all of those are answered. We have should have about 45 minutes worth of speaking, and then we'll have 15 minutes at the end for the Q&A. So with that being said, we are going to start with Austin Oaks Hospital today. We have Colton Treadwell. He's a licensed professional counselor working in the Austin Oaks outpatient program. Before joining the team at Austin Oaks, Colton worked with children in a variety of settings. He has experience in residential treatment, schools, and community mental health. Colton obtained a BA in art and psychology from the University of South in Sewanee, Tennessee, and is in clinical mental health counseling from the Seminary of the Southwest in Austin, Texas. So Colton, I'm going to let you take it from here.
Thank you, Katie. I'm sorry, I'm not Colton, I'm Michael, but I will pass it over to Colton. I just wanted to give him a quick little intro, but we're with Austin Oaks Hospital. We are an acute care psychiatric facility located in South Austin. And so we do crisis stabilization for adolescents, adults, and also exclusively for women. And, it's a great sort of resource to have in any sort of psych emergency, whether it be inpatient or, as Colton does some of our outpatient therapy, working specifically with adolescents. So if you'd like to learn more about Austin Oaks Hospital, feel free to check us out. We're available 24/7 at 512-440-4800. Or on our website at austinoakshospital.com. But without further ado, I will pass the floor over to Colton Treadwell, our licensed professional counselor.
All right. Hello. Thank you all for having me today. Happy to be here. I think that this kind of work is really important, so I'm glad that we're together today. I thought I could start by talking a little bit about my experience and kind of what I'm bringing to this conversation, and then go into some recent data on, specifically suicidality in kids and teens. That's more of my experience, so I hope it's helpful. So as was already kind of summarized, I've worked in direct care at a treatment center before. That was one setting I was in while I was in graduate school, also with special ed classes in Round Rock ISD and in kind of behavior management. So that's where the majority of my experience with kids started. Then after graduate school, I've worked in community mental health for a while, and now I've come to Austin Oaks. So I'm currently the lead outpatient therapist here. We have currently programs for ages 12 and up. Our teen program tends to have a lot of numbers, especially this time of year. We see it start to creep up as school starts. So that's kind of the experience that I'm bringing. If anyone has questions about that, let me know. I think that it's also important to take a minute at the beginning of this to encourage everyone to kind of care for themselves during this talk. This topic can be difficult, especially if you're working in mental health or working with populations that are struggling. It can be a lot. So, taking a minute to maybe care for yourself, maybe plan something after this, because it is a lot to go through. So without any further ado, we'll start with some stats. There's some good information on the National Institute of Mental Health website The Trevor Project has really good resources. There's also some studies that I looked over. So what we're seeing generally is an increase in suicide deaths among children over the last decade. So we're seeing that trend go up. In 2020, suicide was the second leading cause of death among individuals ages 10 to 14. So suicide is now the 8th leading cause of death in children ages 5 to 11. And there's some research that also suggests that most of the time when these are occurring, this is happening in the family home. And I'm happy to send people links to resources or studies if you want to look over any of that data. Usually, if this is happening at home, if there is a completed suicide in the home, it's in a child's bedroom if we're talking about kids. And typically the means that are coming up are hanging or strangulation or firearms. If we think specifically about firearms, most of the time this is when the firearm is not stored properly, meaning like away from kids, obviously. Maybe storing ammo and firearms separately. So definitely some safety considerations to think about if there's firearms in the home. About half the time when there's a completed suicide involving a child, there was a parent home when it happened. So I think that sometimes it's important to know about the context of like when these are happening and what environments we need to look for. So, excuse me, the most common diagnosis that we see from the research that overlaps with suicide attempts would be ADHD, depression, and trauma history. I will say that when you look at the research on suicidal ideation in children, there are definitely gaps. There's not as much good data on this. So I wouldn't be surprised if that kind of changes. But I would say from my own experience that definitely the trauma history is a big piece a lot of the time. Most children who died by suicide have made a suicidal statement in the past, meaning like ever. It's about 80%. And if we're thinking about the day of, it's only about 11%. So it may be that you won't hear a statement the day of, and that doesn't mean that everything is okay, typically. So we need to look for kind of that lifelong assessment of suicidality when we're assessing for that with kids. Specifically, if we're thinking about ideation in LGBT children, we know that LGBT youth are about 4 times as likely to attempt suicide than their peers. If you want more information about that, the Trevor Project is pretty great as far as summarizing that data. And I would definitely refer to them as a resource. We also know that 45% of LGBT youth seriously considered attempting suicide in the past year. So if you're someone who's working in mental health, if you have LGBT youth as your patients, that's just something to keep an eye out for. This is considered a high-risk population. And I think oftentimes in children, this is overlooked. So going through the statistics is definitely depressing. It's a lot to look at, but I think the direction it points us is a hopeful direction, because then we can talk about what we can do to improve that. So some of the things we can do are educating ourselves and others, doing things like this, having these public forums, talking with other professionals, making sure that you have access to people to ask questions, staff things when they come up. Being a supportive adult is a big deal. So supportive generally for any children, but also specifically for our LGBT youth. We know that if they have an adult in their life that's supportive, the rate of suicide does go down. One misconception that comes up a lot is parents especially might worry that asking their children about suicidal ideation or about safety concerns is going to like give them the idea, or it's going to increase the safety concerns. And the research would suggest this is not accurate. So we want to create an environment where it's safe to bring those topics up and it's safe to talk about them when they do come up. Another big one is using people's pronouns. That's been researched and documented that if a teen or a youth has pronouns that they prefer, using those pronouns can be considered suicide prevention. It is a big deal. So taking the time to get that right, and also taking the time to, fix it if you get it wrong, and showing that kind of support. There's also kind of a general sense of making sure we have good access to healthcare, whether that's mental health or otherwise. That would be a big factor. You want to make sure, if you're a mental health professional thinking about what to do, one of the most useful pieces of advice that I got was how to align with your patient or your client. So a lot of times if you're talking to a kid or a teenager who is making suicidal comments, you want to delve into that in a safe way and see, is it about wanting to die, wanting to end your life, or is it about not wanting to feel the way you feel right now? And those can be approached in different ways. So if we are able to align and someone is saying they don't want to feel this way, you can say, I also don't want you to feel this way. Let's work on some strategies to help you feel better, right? So not butting up against that immediately, but kind of letting them express what's happening and then approaching it from a viewpoint of aligning with what they want, which is relief from whatever is happening, if that makes sense. Safety planning is a big piece. We do a lot of that here. So having those emergency contacts established, having people that you can talk to help support a teen or a kid, and make those plans as far as, what are they doing when they're not seeing you? Who are they going to be with? What access to any lethal means might they have? Those are really important considerations. Notifying parents can be tricky if there's suicidal ideation or safety concerns. I found in my experience that if at all possible, it's good to let the patient or client know that you're going to do that and plan on how to have that discussion together if it's safe to do so. So you wouldn't want it to be a surprise. And some of that comes into how we approach therapy initially as well. We want to make sure that we're giving kids or teens a heads up on, these are the things that I will have to share with a parent or guardian if I have these concerns. So making sure that communication is clear and that it's not a surprise, because we don't want to escalate things. Securing means is a big piece of safety planning as well, and talking to parents about how to do that, like how to lock things up, what's considered lethal means, things like anything sharp, especially if a kid is having specific thoughts about a particular way that they may harm themselves, you would need to really focus in on how can we secure whatever that is, whether it's a gun, knife, if it's ropes, things like that. So we would need to be really specific about where that's going, how to plan with the parents on where to lock that away. A few other things that I've just noticed in my work that may be helpful as far as addressing these concerns are making sure that we have really good aftercare. So in our setting, we oftentimes will get kids for not that long. We'll have kids or teens with us for maybe 4 to 6 weeks in outpatient, and we can do some really, really good work in that time. But a big piece is connecting with who the next person is. So that may mean networking with other therapists, figuring out who they're going to see next, what kind of services do they want, and getting kids or teens involved in that process can increase the likelihood that they're going to follow through. So I've had times before where I look online on Psychology Today or through a referral list with a teenager and get their opinion on some people, like, oh, well, what do you think about this person's website? How do we feel about that? And getting them to engage is going to increase the likelihood that they'll continue services, which is what we want from our setting. So another thing would be having open discussions when these thoughts come up. Sometimes what may bring up the discussion might be something from popular media, so maybe familiarizing yourself with what your kids or teenagers are watching. If suicide is part of a plot of a TV show, like I know there are several that have come up over the years on Netflix, and maybe making that an opportunity to discuss that safety or discuss how they feel about that. So we want to make sure we're establishing that there are safe people to talk to. And that also brings me to a point of making sure they have someone they can talk to, even if it's not you. So I will often, safety plan with kids, and part of the safety plan is who are you going to talk to if you feel unsafe? And it doesn't have to be me, it doesn't have to be your mom, but who's it going to be? And we need to plan specifically for who that safe person is and make sure they're a safe person. So I think what might also be helpful is just discussing a little bit more about what we do at Austin Oaks to address those concerns. I know that Michael touched on this a little bit, but we do have inpatient care for ages 12 and up at Austin Oaks. So if we are seeing imminent safety concerns, if we need to stabilize, if we need medication changes, that might be a good option. We're open for assessments 24/7. So if someone does need an assessment to determine the most accurate level of care, then that might be a good way to pursue that. For our outpatient services, we also serve ages 12 and up, and we have partial hospitalization, our PHP program, and intensive outpatient, our IOP program. So those two options are available to people in the community. One of the big advantages in our program is we also have a connection with UT Charter School. So if a kid is currently in school and they're worried about getting services, that they're going to fall behind in school and miss things, we are able to continue their schooling here while they're doing the group therapy. So I have found that teenagers generally do pretty well in our group setting. It can be helpful to just kind of normalize what's happening and see peers who are also struggling and see peers who are improving, and maybe those connections can be helpful. So that's just a little bit about our services, a little bit about stats with kids and teens. I'm happy to answer any questions, or if anyone here has people that they need to refer to us, feel free to contact me directly or contact Michael, and we can get you in touch with the right people. So with that, I think I will pass it on to our next presenter, but thank you all for your time.
Thank you so much for your time. We really, really appreciate it. We're actually going to have Sage Recovery go next. I'd like to say our good friends at Sage Recovery, we've worked closely with them for many years, and they do so much good work out there. We have Ann Gilbert. She's a licensed master of social work. She completed her master's of science in social work from the University of Texas at Austin and earned her bachelor of social work from Louisiana State University. She has experience in working with children and adolescents, and she's passionate about supporting families to provide meaningful collaborative care. She facilitates adolescent groups, offers individual adolescent sessions, and primarily draws from a dialectical behavior therapy DBT approach. She is training to become specialized in radically open behavioral therapy to strengthen her skills in supporting over-controlled populations. So, Miss Ann, take it away.
Hi, thank you so much. I really appreciate the opportunity to be here today. I'm one of our therapists and a lead therapist at Sage Recovery and Wellness Center. And here at Sage, we offer wide scope of services kind of at different levels of care. At our wellness center where I'm located, we offer several intensive outpatient programs with both mental health and substance use diagnosis sort of lenses or focuses. We also offer DBT skills groups for adolescents and adults and individual therapy. At our other location at Sage Villa, we also offer residential services. But I would say that sort of throughout all of our range of services, the primary lens or therapeutic modality that we use is DBT or dialectical behavioral therapy. So I was hoping to come in today and sort of present the DBT lens on suicidal ideation and how we use that to support our clients experiencing suicidal ideation at Sage. So DBT was developed in the 1970s by this woman, Marsha Linehan, who was a suicide researcher at the time. That was her sort of scope of her research. So DBT was initially created and developed specifically for individuals struggling with suicidal ideation. So DBT, of course, is a dialectical model, meaning that we are challenging clients to hold two sort of seemingly opposing truths or contradictory truths at the same time. So dialects can show up for clients in a countless number of ways. This could maybe look like there's someone in my life who I really love and care for, and our relationship can be really challenging sometimes. Or this new thing that I'm learning, that I'm taking on, is really challenging, is really difficult, and I'm capable of doing hard things. I would say that kind of the key dialectic that sits at the core of DBT is sort of this change and acceptance dialectic. So the change side being we are supporting clients to change their ways of thinking, their ways of behaving, the ways that they're responding and reacting to the things in their lives, and offering them new skills to do that. So clients are working really hard to change their way of life. And sort of simultaneously, we're holding this piece of acceptance. So supporting our clients with self-validation, showing themselves loving kindness, self-compassion, and really that showing of acceptance for exactly who they are and where they are right now. So that's kind of that core idea that I think we keep coming back to over and over in this model. disruptions in this sort of dialectical way of thinking can look like all or nothing thinking, black and white thinking, things are all good or all bad, or maybe in some cases, or we as people are all good or all bad. And this more sort of polarized way of thinking can be really emotionally dysregulating for our clients. And so our hope is that guiding them towards this kind of dialectical way of seeing the world might help them find regulation and lower some of those really high intense emotional states. So that's kind of that dialectical piece that we go back to time and time again. But DBT is also a behavioral model, the B in that acronym, meaning that we're aiming to replace behavior that is harmful for clients, is causing problems for clients, with more skillful behavior or less harmful ways of going about things. In DBT, we stay really curious about sort of the function of that more harmful or problematic behavior that our clients come to us with. We stay curious about sort of the relief that clients might find from their behavior. So relief from the distress in their lives, painful emotions, or things in their world that are really unbearable. And we're curious about the reward that clients might get from some of this harmful or problematic behavior. So the things that they gain, maybe the support that they get from other people, or any sort of more positive emotions that might come from it. And so we take the same lens with suicidal ideation. We know for some of our clients, we hold and accept the distress and the unbearable emotions that come with suicidal ideation. And we explore with them ways that behavior might be giving them sort of a sense of relief from a really unbearable environment or state of life that they might be in. And we stay curious about the rewards they might get. Maybe in that suicidal state, they're receiving a lot of help and validation and kind of really getting the help that they need. And we never want to take relief or reward away from our clients. So when working with suicidal individuals, we want to explore with them how we can still help them find relief from the really intolerable things about their reality and keep the support and the validation and maybe all of the providers and people on their care team that the client is benefiting from, but maybe plugging in some new skill and shifting up that more harmful behavior. So that's kind of the DBT lens in a nutshell. And so when we work with a client, we sit down with them initially to identify or pull out what we call our target behaviors. So these are the really specific behaviors that the client is telling us that they want to shift or want to change in their work with us. The number one thing that we're always going to go to first with our work with clients are safety targets around things called life interfering behavior, or the harmful behaviors that might really threaten our physical safety. So suicide ideation always being on that list and always something that we ask about no matter who walks in the door. And with safety being a number one priority, we check in around safety every single group session with all of our clients, and we always make sure to pull them out and participate in safety planning as needed. When working with adolescents and youth, a big piece of that is exploring kind of what other safe adults, as mentioned earlier, could be part of that safety plan. So those are just a few of the safety measures that we kind of keep coming back to time and time again. DBT's sort of catchphrase, I guess, is building a life worth living. And that's ultimately what we're hoping to do with our clients. We're here to explore what that life might look like for every individual client, because of course, that life worth living is going to be really different for everyone, and offer them both the tools for change and the support and the acceptance that they need to begin working to build that life for themselves. We also sit down with each individual and get really curious about what we call vulnerability factors, or things that might make a client more vulnerable to suicidal ideation or vulnerable to really high emotional, intense emotional states. So we know that that can look like a number of things, maybe a history of chronic illness, family history of different things that they might come to treatment for, a history of trauma, bullying, especially if we're working with adolescents. And so those might be some of our more chronic or bigger vulnerability factors. And that goes all the way down to maybe sort of the day-to-day annoyances or things that get in the way of us just sort of going about our lives. So we really take time to focus on those vulnerability factors with our clients as well. And again, being aware of those might support our clients in building a life worth living. So one way that we might be able to support friends and family with suicidal ideation is by helping them with the change piece and helping them with the acceptance piece. So if we know that there are certain skills or tools that are helpful for that young person, that adolescent, that loved one of ours, maybe we can encourage them to lean on those skills and even offer to do those skills with them. So maybe, hey, let's just sit here and take a break and breathe for a minute. Maybe let's go for a walk together. In DBT, we recognize that even changing the temperature in our bodies can be helpful when we're really dysregulated. Holding ice cubes is something that a lot of our clients, I think especially our adolescents, come back to. So hey, I'm gonna go get some ice. Like, let's sit here and hold some ice cubes for a minute. Could just be some of the ways that doing change kind of with somebody could be supportive. And then of course, we also can support with that acceptance piece. So showing compassion for our loved ones, showing them that loving kindness, and validating them when they're sharing how they feel with us are big ways of doing that. When we are validating a loved one, we don't have to approve of or agree with every single thing that they're telling us. It's really about deeply listening to that person, showing them that they're seen and heard, and maybe saying like, wow, like I'm really hearing how intense this is for you, and it really makes sense why you might feeling that way, given maybe what's been going on, or given how vulnerable you're feeling, or kind of whatever's going on for that person. So in the DBT model, maybe anyways, we could support our loved ones with both that change and acceptance piece. So ultimately though, connecting our loved ones with the mental health sort of community and that we have of all these different providers, and getting them in touch with the right providers is going to be a huge piece of recovery for a lot of people. I definitely want to reiterate that asking someone about suicidal ideation cannot plant the idea into their head. We're not that powerful, sort of transfer that idea to someone. So asking about it, I think, is definitely a prevention measure we can take. You can also call a suicide hotline as a third party if you're curious about support or have any questions. They'd be happy to answer those. But finally, our recommendation that is, if we are really feeling afraid that someone is at risk of harming themselves or someone else, that we either call 911 or get that person in for an emergency assessment. So that was kind of, I think, the bulk of what I had for y'all. Thank you so much for listening, and hope that at least the DBT lens that we take on has been helpful.
And thank you so much. And unfortunately, our other speaker was not able to join, so we're just going to have the two speakers for today. So that was so much wonderful information. I actually want to get started off with the Q&A and have a quick question. So for somebody that has, a family member people that have had family members or friends that have dealt with suicide, I feel like they kind of know the path to go down if that battle that they're fighting, but if somebody has a friend or family member that they've never had to deal with that in their entire lives, of somebody being suicidal or trying to help them or these types of behaviors, like where do you start with that? When you don't know where to go or what to do, is it best to get in touch with one of y'all's facilities? Like what do the parents need to do or friends to help this person?
I would say a good starting place would be, even just thanking them for telling you, like establishing that relationship, making sure that they feel like it's safe to talk to you about it. And having someone disclose that they've had suicidal thoughts doesn't automatically mean that they need inpatient psychiatric care. So maybe approaching with them what they need, what are their needs right now. Maybe it's as simple as, I'm not feeling safe, I don't want to be alone today, right? How can we safety plan and stay with them for the next day or so? And then think about, do we need some individual therapy? Do we need higher level of care? What does that look like? If it's imminent, then I would recommend an assessment. Like I said, you can come to Austin Oaks or, a similar facility. But the assessment is also something that is just there to let you know what might be a good next step. It doesn't necessarily mean that you have to then go inpatient immediately. So maybe normalizing that process. And if parents are more familiar with what actually will happen if they go for an assessment, that could be a good starting place to just offer that up as an option.
Okay, wonderful.
Absolutely, yeah. I think sort of an idea or assumption I've heard from a lot of families is that if an adolescent does disclose, especially in working with families, if an adolescent discloses suicidal ideation, then that suddenly means that they're going into residential treatment. So I think absolutely meeting that person where they are is going to be huge, offering that acceptance and that validation right away, and really making that connection before sort of being curious about what options for support are on the table for that person, what they're wanting to do, maybe seeing if there are any other providers that we could at least call and ask and see what this person might be needing, given maybe how intense those suicidal ideations are for them, and going from there. Yeah, but I think sort of keeping the person disclosing the information in the driver's seat and keeping them in control of their treatment as much as we can is going to be a really big piece of their recovery.
All right, wonderful. Thank you so much. Does anybody else have any questions at this time?
Yeah, thanks guys. Really, really awesome info and like such a careful topic really to be approaching. But I wonder also, like, I've encountered before people's like individualized like mental health plans, basically. So folks who kind of, like given their own mental health histories, or just they want to be prepared for the future, they'll like gather a sort of like tips and best practices for their friends, loved ones, spouses, family members, to have sort of like in advance of a moment. So things like, when I reach a super stress point, it's helpful for people to hold my hand or give me a cold ice pack for the back of my neck. But it's not helpful for people to ask me what I need, right? Like because for some people, that's like not what feels good to them. And so I wonder, like, does Austin Oaks or Sage Recovery have any of those like preemptive programs for people, for them to like really learn in advance about what they can do to prevent suicidal, I mean, you can't really prevent suicidal ideation, but like to be in a space where that wouldn't come up, or if it does, to like have a kind of like care network around them in advance who knows how to work with them and deal with them safely?
We certainly do. At Austin Oaks, the way that we approach that is we start off with safety contracts, and included on that is information about what those preferences are, what coping skills we like and what we don't like. And especially with our teens and kids, we'll go through that with them and kind of run through, okay, I'm noticing here that you said if I feel escalated, this is the kind of support I want, right? And so that kind of tracks, because you may have a kid that says, I really need to talk about it when I don't feel good. And you might have a kid that says, I really need to not talk about it and I need to be distracted, right? So maybe like building those coping skills initially is a good starting place, because that could give them options. And if a kid or a teen is feeling overwhelmed by kind of that open-ended question of like, what do you need? Then parents or caregivers could offer them a choice. So maybe if we know they have some coping skills, you could say, do you want to hold some ice cubes? Do you want to do deep breathing, or do you want to go on a walk? Instead of just saying, what do you need? Because that can feel really hard in the moment. So I think that initial planning is important, and whether that's with a therapist or with a parent, I mean, anyone can kind of compile what are those things that are going to help you and what do you not want from us, right? Because we don't want to escalate it, obviously. But yeah, I'm glad that you brought that up. I think the kind of preemptive planning is really important, so that when we are escalated, we already know what we're going to do. We don't have to then reinvent the wheel when we're not feeling well, right?
Yeah, I think we take kind of a similar approach at Sage Recovery, working with families. We ask about client preferences right at that intake assessment. So we definitely want to be aware of what's helpful for clients right out of the gate, and build on what is already working. We think, especially working with adolescents, meet with families several times throughout the course of their treatment. And so at that first meeting, we might talk about what skills a young person might need when they're sort of at a 10 in that crisis state, all the way on high on the distress scale. What are going to be the safety measures and supports in need? Once we have that sort of plan for when a client's at a 10 in place, a lot of the times we'll kind of start to work backwards with families. So maybe in a couple of weeks, we'll check in with a family and see like, okay, we've got some skills for when we're at a 10, but what about when we're at a 7? So still feeling really dysregulated, still have a lot of stuff going on, but may not need the same sort of skills or intervention or level of care as we do when we're at a 10. So maybe a couple of weeks later, we can build out that plan for what a 5, for what a 3 looks like. And kind of keep it like this working, rolling safety plan that we can change up and adapt, and can stay flexible as the client is learning more skills and exploring and sort of trying on new things, and then as we're learning more about what does and what doesn't work for them.
Awesome. Thanks, you guys.
Okay, do we have any other questions at this time? You're more than welcome to unmute yourself and ask away. All right, well, we're going to get out with a few minutes to spare before the 1 o'clock hour. So I want to thank everybody again for your time today. Like I said, this will be posted on the website, and so please share it with friends and family. I feel like it's a lot of information that a lot of people really need right now. So thank you so much, and we'll see you next time.
Guys.
Thank you.
Thank you
Thank
so
you.
much.